Hello everyone, I think I'm live. Mhm, mhm, mhm. So, hello everyone, this is Dr. Mandeep, and I hope everyone's doing great on Mondays. All of us do dread Mondays, but it's a good day to start and learn new things. So, yeah, that's why we are here to learn about drugs for heart failure, right? So yes, before we start with that, I'll wait at least 5 minutes so that everyone gets into the live stream and we will discuss about those topics that we are going to rock. So yeah, so how's everyone doing? Um, is it a great evening in other countries? Tell me about it. Um, so how many of you are here right now? I believe four of you are here right now with me, and yeah, what's up, everyone? Hmm. Okay. Um. I want to apologize for the delay in the YouTube live that happened on Saturday. There were some technical glitches, and it is past right now. So here you are. Hi, Anmol. Hello, Neetu Chand. How are you? There's someone called Kidzi. Hello, Kidzi. It's great to have you all around, and I would like more people to join. And around 6:30, we can go till 6:35 to wait for more people to join the live stream so that we can start. And I want this to be a learning exercise rather than a lecture, right? So if you have any questions, post them in the YouTube comment section, and I'll go through them and we'll discuss those, right? Hello, Sahil. Thank you for being patient, guys. Yeah. So, but before we start with this lecture, let's discuss um, why 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 do we want to learn about these drugs in the first place? So, let me tell you one story. Uh, there was one patient when I was posted as a cardiology resident in one of the wards. Um, he came to us with shortness of breath, swelling in his feet, and he had heart failure. And at presentation, he had hypokalemia. So we went through the number of drugs that he was having when he presented to us, and we kind of ruled out what were the causes of hypokalemia in that patient, whether it was due to the disease he was having or drugs. Somehow in the history, what we missed was one particular drug that he was taking, and it was not on the list. And it was through talking with the relative, उसके रिलेटिव से हमने बात करी एंड देन ही वी केम टू नो कि हाँ वो एक पोटेशियम स्पेयरिंग डायूरेटिक ले रहा था एंड दैट इज हाउ वी फिगर आउट दैट ही हैड हाइपरकैलेमिया. So studying about these drugs is important because their side effects are can be very dangerous. And this patient, even though he had shortness of breath, his potassium was 8. His potassium was 8, and that can lead to cardiac arrest. And that much high potassium can stop the heart, stop the blood supply to the brain, and the patient might die. Right? So it is important for us to know about these drugs because they do save patients' lives. They do save patients' life, but in some cases, patients do have side effects. And obviously, aldosterone receptor antagonists have hypokalemia as a side effect, and we were able to figure it out in this patient. So yeah, hello, Dr. Aditya. How are you? Hello, Dr. Kiran. So it's 6:31. Yeah, 4 minutes, 4 more minutes to go before we start this lecture, right? Um, hmm. So I think uh, we have 15 participants with us, and I believe we can go now. Like I was saying that we would wait till 6:35. तो अभी start कर लेते हैं. हमारे पास participants enough है, and this is going to be recorded, and we will make sure all of you learn this with dedication, right? So शुरू करते हैं. अम, हम हमारा लेक्चर पहला पहला पार्ट ये रहेगा कि हम पैथोफिजियोलॉजी डिस्कस करेंगे, राइट? तो अंडरस्टैंडिंग पैथोफिजियोलॉजी इज की टू अंडरस्टैंडिंग हाउ यू आर गोइंग टू एड्रेस द डिजीज, है ना? तो अगर आपने पैथोफिजियोलॉजी अंडरस्टैंड कर लिया, यू आर गोइंग टू गेट ईच एंड एवरी ड्रग राइट. ओके, सो बी विद मी. तो हार्ट फेलियर का मोस्ट कॉमन कॉज क्या है? हार्ट फेलियर का मोस्ट कॉमन कॉज है कोरोनरी आर्टरी डिजीज लीडिंग टू मायोकार्डियल इन्फार्क्शन, राइट? सो कोरोनरी आर्टरी डिजीज is the most common cause of heart failure because of acute myocardial infarction. तो अब नेक्स्ट क्वेश्चन हमारे दिमाग में ये आएगा कि कोरोनरी आर्टरी डिजीज क्या है? कोरोनरी आर्टरी डिजीज एक ऐसी डिजीज है जिसमें जो ब्लड सप्लाई है टू द हार्ट इज ब्लॉक्ड तो कोरोनरी आर्टरी डिजीज में होता क्या? तो इफ दिस इज योर ब्लड वेसल यहाँ पर एक प्लाक रहेगा. तो व्हाट डज दिस प्लाक कंसिस्ट ऑफ? इसमें फैट और फाइब्रोब्लास्ट रहेंगे. तो whenever there is stress, तो ये जो स्ट्रेस है इस प्लाक को रप्चर कर देगा. So when it ruptures, what it does, रप्चर के बाद प्लेटलेट एडहेजन और प्लेटलेट एग्रीगेशन होगी. तो उससे क्या होगा? When platelet aggregation and adhesion occurs, तो certain amount of chemicals are released that coagulation. They activate the coagulation. So once that occurs, तो यहाँ पे जहाँ पे प्लाक था जो रप्चर हुआ था, that will form a thrombus here. So the blood supply to the heart has been completely blocked. जो blood supply है वो completely block हो चुका है, right? So what would it lead to? Ischemia. और इस्कीमिया से क्या होगा? इस्कीमिया से होगा सेल इंजरी. जो सेल इंजरी है वो किस टाइप की होगी? वो होगी इरिवर्सिबल सेल इंजरी। सो हमने एक पैथोलॉजिकल प्रोसेस को भी स्टडी किया। वो क्या था कि कोरोनरी आर्टरी में एक प्लाक था जो कि अंडर स्ट्रेस आया। जब उसके अंदर स्ट्रेस आया तो वो रप्चर हो गया। सो रप्चर होने के बाद प्लेटलेट्स क्या हुए? एक्टिवेट। प्लेटलेट्स क्या हुए? एक्टिवेट। प्लेटलेट एक्टिवेशन और प्लेटलेट एडहेजन की वजह से आगे कोगुलेशन एक्टिवेट हुआ, जिसने क्या बनाया? थ्रोम्बस। थ्रोम्बस ने कोरोनरी आर्टरी को ब्लॉक किया, जिससे क्या हुई? सेल इंजरी। जिससे क्या हुई? सेल इंजरी। एंड देन दैट सेल इंजरी वाज इरिवर्सिबल सेल इंजरी। इरिवर्सिबल सेल इंजरी। तो हम आगे जाते हैं। इस इरिवर्सिबल सेल इंजरी से आगे क्या होगा? तो सेल इंजरी हुई है तो क्या होगा? डेथ। किस चीज का डेथ? मायोसाइट का। जो हार्ट मसल है दैट विल डाई। दूसरा प्रोसेस क्या होगा? दूसरा प्रोसेस है that is fibrosis, or you can call this healing, right? तो फाइब्रोसिस या हीलिंग इनिशिएट होगी वंस सेल डेथ हैज अकर्ड। सेल डेथ हैज अकर्ड। तो ये दो प्रोसेस हुए। तीसरा प्रोसेस क्या होगा इसके बाद? तीसरे प्रोसेस को अंडरस्टैंड करने के लिए हम एक प्रिंसिपल को याद करते हैं। उसको बोलते हैं फ्रैंक स्टार्लिंग लॉ। फ्रैंक स्टार्लिंग लॉ। सो फ्रैंक स्टार्लिंग लॉ में क्या होता है? फ्रैंक स्टार्लिंग लॉ का मतलब है जितना हार्ट मसल स्ट्रेच करेगा, जितना हार्ट मसल स्ट्रेच करेगा उतना फोर्स ऑफ कंट्रैक्शन बढ़ेगा, उतना फोर्स ऑफ कंट्रैक्शन बढ़ेगा। तो इससे क्या हो सकता है? जब ये चीज़ लंबे अरसे के लिए कंटिन्यू हो जाती है तो इट लीड्स टू थिकनिंग, थिकनिंग ऑफ हार्ट मसल, जिसको बोलते हैं हाइपरट्रोफी, राइट? हाइपरट्रोफी। सो तीसरा प्रोसेस जो है हमारे पास वो है हाइपरट्रोफी। फोर्थ, जो फोर्थ चीज़ है जो जिस पे हमने कंसंट्रेट करना है, बिकॉज सेल इंजरी हुई, इरिवर्सिबल सेल इंजरी हुई, तो जो सेल के अंदर कुछ पंप्स थे, उनमें से कौन से पंप्स जिनके बारे में हम जानते हैं वो हैं सोडियम पोटाशियम एटीपीएस पंप। जब ये फेल हो जाते हैं तो क्या होता है? जो सेल है वो डीपोलराइज्ड हो जाएगा। जो सेल होगा वो डीपोलराइज हो जाएगा। तो जो परमानेंटली डैमेज सेल रहेंगे वो परमानेंटली डीपोलराइज हो जाएंगे। तो ये प्रोसेस हो कहाँ रहा है? ये हो रहा है लेफ्ट वेंट्रिकल के अंदर। लेफ्ट वेंट्रिकल के अंदर, राइट? एक मिनट। यस। सो अगर हम यहाँ ड्रॉ करें तो जो if this diagram represents, this is the left ventricle, this is the right ventricle, right? So जब भी for example अगर ये वॉल है लेफ्ट वेंट्रिकल का और इतने एरिया की ब्लड सप्लाई गई है completely, it means the patient has suffered from acute myocardial infarction of this area. This area will have myocyte loss जब मायोकार्डियल इन्फाक्शन होगी, उसके बाद हीलिंग होगा जहाँ पे फाइब्रोसिस होगा, एंड देन इट विल ऑल्सो हैव hypertrophy, it will have hypertrophy, and then it will also have depolarization. This area which is infarcted, which has lost its blood supply, which has undergone irreversible cell injury, will be permanently depolarized, right? I believe everyone has followed. So the next thing to concentrate at is what are the three important uh, outcomes of acute myocardial infarction on left ventricle. These are LV dilation, LV dilation. Second is LV thinning, and third is impaired contraction, impaired contraction. So let me tell you visually what happens here. So in dilation, let's just say if this was the normal left ventricle and the right ventricle. So once the infarction has occurred and some time has passed so that fibrosis, hypertrophy can occur, so the left ventricle would look like this. If this is the right ventricle and this is the left ventricle, you can see that if this is the normal shape and this is how the left ventricle looks once it dilates. The next thing to look at is ventricular thinning. Let's just say if this is the normal thickness of the left ventricle. So once scarring or fibrosis has occurred and myocyte loss has been there, this thickness would reduce to this much. This thickness would reduce to this much. There is thinning of left ventricle. There is thinning of left ventricle. Because there is myocyte loss, the contraction would be impaired. The contraction would be impaired. So let's move on to the next phase of this pathophysiology. So once there is impaired contraction, I hope this is visible to everyone. Once there is impaired contraction, the end systolic volume will rise. End systolic volume will rise. So what is end systolic volume? It is the amount of blood remaining in the heart after a systole or the left ventricular contraction, right? So once end systolic volume rises, what would happen to the ejection fraction? It will fall, right? So it would fall or decrease. Once the ejection fraction falls, the cardiac output would fall. The cardiac output will fall. So if we see in the diagram or the flow chart here, once heart failure sets in, it reduces cardiac output. When cardiac output decreases, the renal blood flow decreases. The renal blood flow decreases. And this is one of the important mechanisms that activates the RAAS. And what is RAAS? RAAS is Renin-Angiotensin-Aldosterone System. That is Renin-Angiotensin-Aldosterone System. So, yes. As the GFR falls, there is a release of renin. And this is the important mechanism for heart failure. And all of the drugs that we are going to study in the lecture later are based on this RAAS system activation. So let's recap this. There is impaired contraction, which leads to rise in end systolic volume. This decreases the ejection fraction and which decreases the cardiac output. Once cardiac output decreases, renal blood flow decreases and there will be release of renin, and this activates the renin-angiotensin-aldosterone system, right? So let's move on to the next slide. How does angiotensin 2 is formed in the body? So liver is the primary site for synthesis of angiotensinogen. Liver synthesizes the angiotensinogen. while kidney synthesizes renin. Kidney synthesizes renin. And what are the cells which synthesize renin? They are juxtaglomerular apparatus. They are the juxtaglomerular apparatus. Fall in cardiac output is not only the stimulus for renin release. There are sympathetic fibers which stimulate the beta 1 receptors. The beta 1 receptors which lead to release of renin from the kidney. So angiotensinogen, which is synthesized in the liver, is converted to angiotensin 1 by renin, which is made in the kidney, right? So next, let's move on to the next reaction. So angiotensin 1 is converted to angiotensin 2 by ACE. And what is ACE? It is angiotensin converting enzyme. Angiotensin converting enzyme. So this angiotensin converting enzyme, it converts angiotensin 1 into angiotensin 2. And what are the particular cells that make angiotensin converting enzyme? That is endothelial cells of pulmonary capillaries. Pulmonary capillaries. So let's recap this. Angiotensinogen synthesized in the liver is converted to angiotensin 1 by renin, released by kidneys via juxtaglomerular apparatus, which is then converted to angiotensin 2 by angiotensin converting enzyme synthesized in the endothelial cells of pulmonary capillaries. Right? I hope everyone got this. Let's move on to the next slide. So, angiotensin 2, now it has to activate the aldosterone also, right? So it acts on the adrenal cortex to release aldosterone, So before we move on to the next slide, let's see what's in the adrenal cortex. So adrenal cortex is made of three layers. Made up of three layers. These are GFR, G, F, and R. The first layer is called zona glomerulosa. Zona glomerulosa. The second layer is called zona fasciculata. Zona fasciculata. And the third layer is zona reticularis. Zona reticularis. So the aldosterone is released from zona glomerulosa. So angiotensin 2, it acts on zona glomerulosa to release aldosterone. It is important to remember angiotensin 2 is not only the releaser of aldosterone from the adrenal cortex. What is the other stimulus for aldosterone release in the system? Can anybody guess? Comment section. Anyone? What's the stimulus for aldosterone release from the adrenal cortex if angiotensin 2 is not there? Anyone? So if you have got the answer in your mind, great. If you haven't, I'll type it here. Hyperkalemia is one of the most important stimulus for aldosterone release in the body, right? So let's just say someone has a potassium of 8, their aldosterone will be high, right? Similarly, if angiotensin 2 is high, aldosterone would be high, as we studied right now. So let's move on to the next slide. Renin-Angiotensin-Aldosterone system, where angiotensin 2 is synthesized. This angiotensin 2, it acts via two receptors. there are angiotensin 1 receptors, and then there are angiotensin 2 receptors. The angiotensin 1. So these are the bad guys. These are the bad guys. And angiotensin 2, they are the good guys. That is why angiotensin 2 via AT1 receptors leads to the pathology. What pathology? Chronic heart failure. Chronic heart failure. And if we want to have positive effects, these are present via AT2 receptors, because these are the good guys. These are the good guys. So let's move on to the effects of angiotensin 2. So there are 6 important effects of angiotensin 2 that we need to remember in pathophysiology. So the first effect is seen in blood vessels. In blood vessels. So in blood vessels via AT1 receptors, they would cause smooth muscle. They would cause smooth muscle contraction. Once smooth muscle contraction occurs, what will it do? Vasoconstriction, right? Vasoconstriction. Now, AT1 receptor again here in the heart, what would they do? And I remember we discussed in the first slide. Let's go to the first slide. What did we study here? We studied that there is deposition of collagen and fibroblast leading to fibrosis. These AT1 receptors, in the heart, they lead to remodeling and fibrosis. They lead to I'm sorry. Excuse me. So the AT1 receptors in the heart would lead to remodeling and fibrosis. Similarly, in the kidney, in the renal tubule, via AT1 receptors, we would increase sodium and water reabsorption. Sodium and water reabsorption. In the second effect of kidney, that is at the level of glomerulus. At the level of glomerulus. This glomerulus is injured by constriction of efferent arteriole. Efferent arteriole. Excuse me. So, efferent arteriolar constriction leads to glomerular injury, and which leads to nephropathy, Now, we have already studied that angiotensin 2 leads to release of aldosterone from the adrenal cortex, right? And this angiotensin 2, it also causes secretion of ADH, which is also called vasopressin from hypothalamus and posterior pituitary. So yes, ADH secretion via V2 receptors in the kidneys, they lead to increased expression of aquaporins. What are aquaporins? They are water channels which absorb, obviously, water. That is H2O. So there are 6 important effects of angiotensin 2 that we need to remember. That is vasoconstriction, cardiac remodeling, increased sodium water resorption, then is nephropathy through efferent arteriolar constriction, 5th is aldosterone release, and 6th is ADH secretion. With regards to these 6 effects, there are two more important aspects that we should remember, that once heart failure has set in, the sympathetic nervous system, it activates. Why? Because the cardiac output, it falls. The cardiac output falls. And the sensitivity, excuse me, and the sensitivity of the system towards these effectors, including angiotensin 2, aldosterone, and norepinephrine released from that, is increased. So all the sympathetic nervous system effects would be increased. The sensitivity towards angiotensin 2 and aldosterone will be increased, and this is detrimental towards heart and leading to chronic heart failure. Now let's go to the next slide. The site for aldosterone, for action is collecting tubules or collecting ducts. So these collecting tubules and collecting ducts, what do they have? They have two kinds of cells. So the first cell is the principal cell. The first cell is a principal cell. The second cell that is important to study is alpha intercalated cell. The alpha intercalated cell. So this is the principal cell and this is the alpha intercalated cell. The principal cell has three important channels. These three important channels are labeled here. The first one is here, the second one is here, and the third one is here. In the alpha intercalated cell, there is one important channel. Now, this is the luminal side of the renal tubular cell, and this is the blood side of the renal tubular cell. This is the blood side of the renal tubular cell. So, this luminal side has two channels on principal cells, and the blood side has one important channel in the principal cells. And the alpha intercalated cells, they have one important channel on the luminal side. So the principal cell, the first important channel is epithelial sodium channel. The epithelial sodium channel. And the second important channel is the potassium channel. The potassium channel. Right? And on the blood side of the principal cells, we have sodium potassium ATPase pump. Sodium potassium ATPase pump. So what does aldosterone do? So aldosterone has intracellular receptors. Let's just say if this is aldosterone, it would enter the cell, bind to the receptor here, and would increase the expression of channels which are epithelial sodium channels and potassium channels. And how does aldosterone enter the cells? It is because aldosterone is a steroid hormone. So because it's steroid hormone, it is lipid soluble. So it enters the principal cell to act on receptors inside the cell, which changes gene expression, and then what it does change? It changes the synthesis, or increases the synthesis of three channels, which are epithelial sodium channels, potassium channels, and sodium potassium ATPase pump. So what it does? So once the expression of epithelial sodium channel increases on the luminal side of the principal cell, there is there is increased absorption of sodium, increased absorption of sodium. Since sodium is a positively charged ion, since sodium is a positively charged ion, there is a negative electrochemical gradient. There is negative electrochemical gradient produced inside the lumen, which will derive potassium inside the lumen, leading to potassium loss. Similarly, aldosterone has intracellular receptors. Here in the alpha intercalated cells, it would enter inside them. If this is aldosterone, it will increase. I haven't described this channel. This channel is a hydrogen. This is a hydrogen ATPase channel. Hydrogen ATPase channel. And what it will do, it will increase the excretion of hydrogen ions. It will increase the excretion of hydrogen ions into the lumen, where it will combine with ammonia to be excreted in the form of ammonium chloride or other salts, right? So yes, let's move on to the next slide. I believe we have already described this. So principal cells, they have epithelial sodium channels on the luminal side and potassium channels on the luminal side. So what it does, aldosterone increases epithelial sodium channels and potassium channels. So what it does is it causes sodium absorption, causes sodium reabsorption and potassium excretion. Similarly, this sodium potassium ATPase pump helps it. Sodium potassium ATPase pump helps it. Similarly, alpha intercalated cells, they have increased expression of hydrogen ATPase channel, which will cause increased acid excretion. So what would be net effect? There would be volume expansion. And what do I mean by volume expansion? I mean is the sodium, when it's absorbed, the water will be co-absorbed with it, and the blood volume will rise. And that is what I mean by volume expansion. And then it will cause, because potassium is being excreted, it would cause hypokalemia. Similarly, because hydrogen is being excreted, what it would cause? Alkalosis. So I think everyone has followed. So the net effect of aldosterone is volume expansion, hypokalemia, and alkalosis. This principle of action of aldosterone is important because we are going to use drugs which will affect aldosterone, right? So it is important to remember that aldosterone causes hypokalemia and alkalosis, rather potassium excretion and hydrogen excretion, right? So let's move on to the next slide. So in a failing heart, we were discussing three things. What were those three things? These three things were LV dilation, right? Second was LV thinning, right? Last was impaired contractility. These three pathophysiological mechanisms are important for chronic heart failure. right? So whenever there is dilation, why does the heart dilate? It is because if the muscle fiber has been replaced by fiber, right? So if this is the left ventricle, and if this is the area, and this is the right ventricle, and see, so this is the left ventricle, this is the right ventricle, and if this is the area where the infarct happened, this would be excessively thinned. So this area, as we were discussing previous also, this area has been infarcted because the amount of blood is increasing here. The amount of blood is increasing here. What it would do, it will stretch, it will stretch the left ventricle. So when left ventricle is stretched outside like this, towards outside, what it would do, it would release a chemical known as BNP, the chemical known as BNP. Similarly, if this is the heart and this is the left atrium and this is the left ventricle and this is the right ventricle, if there is increased amount of blood, and this will stretch the left atrium, this will stretch the left atrium, it would release ANP. It will release ANP. So why is this important? It is because these two chemicals are the saviors. These are the saviors of failing heart. Failing heart. So these are the saviors of failing heart. So why do we call them as the saviors? Let's elaborate on that. Right? So ANP is atrial natriuretic peptide. Atrial natriuretic peptide. And what is BNP? BNP is brain natriuretic peptide. Brain natriuretic peptide. Right? So what do these peptides do? These peptides, they cause vasodilation. They cause vasodilation. And this is exactly opposite effect of angiotensin 2. Angiotensin 2. And what do? They decrease the amount of sodium and water reabsorption. Where? In the kidneys. In the kidneys. Right? Similarly, they decrease remodeling in heart. They decrease remodeling in heart. So it is very common. It is very common for people who are in heart failure to have high BNP, especially if they are in acute heart failure. Acute heart failure. Since we are studying about chronic heart failure, this point is important because to diagnose a patient with acute heart failure, if BNP is normal, the possibility of acute heart failure is unlikely. Why? Because for acute heart failure to happen, the muscle should stretch. The muscle should stretch. Once the muscle stretches, it releases BNP and it should be very high. If it's low, do you think there is a possibility of acute heart failure? No. But in chronic heart failure, you can have borderline high BNP, and it's hard to say whether someone has chronic heart failure or not, because there are other causes of high BNP, right? Which we won't be discussing right now. But for diagnostic purposes and ruling out purposes, acute heart failure has high BNP. Usually it has high BNP. And if the BNP is low, acute heart failure is ruled out. So this is one of the important points to remember regarding BNP, that it can be used to rule out acute heart failure if you're thinking about that in a patient, right? So yes, uh, BNP. So we studied BNP because it's the savior of the heart. Because it's the savior of the heart, we want to use that in treatment. That is why we are studying it. So BNP is degraded into its byproducts by an enzyme called neprilysin, and this is very important. This is very important because one of the drugs that we are going to use for heart failure would be a neprilysin inhibitor. Would be a neprilysin inhibitor. There is one more important point. There is one more important point that neprilysin also degrades angiotensin 2. Yes, it is important. So we'll discuss the relevance of this once we discuss drugs. So let's move on to the next slide. So it is important for us to review some effects of angiotensin 2 on kidneys, especially the glomerulus. So why? It is because there are certain side effects which are relevant to the kidney, which are relevant to the kidneys. So yes, so if this is the glomerulus, if it's the glomerulus here, this is the Bowman's capsule. These are the capillaries. These are the capillaries. So these are the capillaries here. So the blood is coming from here. The blood is coming from here, from the efferent arteriole, and the blood is going out from the efferent arteriole. So blood comes here, and the filtration occurs across these membranes, these capillaries, and this leads to the formation of urine. Or the filtered solute goes here in the proximal convoluted tubule. And we won't go to the details of this. What we are interested here is that angiotensin 2 has receptors on the efferent arteriole. So once angiotensin 2 acts on angiotensin 1 receptors, because we know that these are the bad guys. Right? So these bad guys, what do they do? They cause vasoconstriction. So once vasoconstriction happens here, the pressure here will rise. So rise in pressure in the glomerulus. What it does is it causes injury. This injury leads to nephropathy. And the rise in pressure is actually the hydrostatic pressure, which causes increased filtration and injury. So let's discuss a bit about hydrostatic pressure before we proceed to the next slide. So inside this, inside a blood vessel or the capillary, let's just say, the amount of pressure that is filtering out the fluid is the hydrostatic pressure, right? So the constriction of efferent arteriole causes rise in hydrostatic pressure. And how? Let me tell you a bit simplified diagram. Let's just say if this is a pipe this is the pipe, right? If I stop, put a stopper here, if I put a stopper here, or if I make sure that this becomes a bit narrow, the pressure here will rise. The pressure here will rise. It is similar to a pipe. If it's blocked from this side, the pressure here up to this much would rise. That is why it is leading to rise in hydrostatic pressure. That hydrostatic pressure is causing filtration, and obviously it is increasing the filtration process. At the same time, it is injuring the glomerulus, right, and leading to nephropathy. So let's move on to the next slide. So acute kidney injury is one of the important side effects of drugs used in uh, heart failure, and one of them is angiotensin receptor blockers. Angiotensin receptor blockers, right? And the second category is ACE inhibitors. The ACE inhibitors, right? These two drug categories, what would they do? These ACE inhibitors, they would decrease angiotensin 2, while these receptor blockers, they would block the action of angiotensin 2, right? So what it would do? It will cause vasodilation. It will cause vasodilation. This vasodilation will decrease the hydrostatic pressure, which would give a positive effect on kidneys, in general. However, the effect is not always beneficial. Why? If the blood, if the blood coming from this side is already low, or or the blood supply is low, the pressure within here is already low. If we vasodilate this area, the pressure becomes so low that the GFR, the GFR, the GFR, it falls. It falls. So already compromised glomerulus, if you give them an angiotensin receptor blocker or ACE inhibitor, it will cause vasodilation in the efferent arteriole, which will further decrease the filtration pressure here and shut down the kidney. And where it would land? Acute kidney injury, right? So this is one of the important effects of angiotensin receptor blockers and ACE inhibitors, right? Another effect. So ACE inhibitors, they 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 also degrade bradykinin. They degrade bradykinin. So once you inhibit the ACE enzyme, the increases. Bradykinin increases. So increase bradykinin. So what it does? It causes angioedema. Angioedema. So angioedema in itself is a dangerous side effect. Why? Because it can cause airway compromise and collapse of the hemodynamic parameters, leading to shock. So we are done with this, and let's review drugs for chronic heart failure. But before we do this, let's go back and review all of this. So let's start from the first slide. So the first slide said that patients who underwent acute myocardial infarction, they had myocyte loss, fibrosis, hypertrophy, and had permanent depolarization in the left ventricular cells, which leads to abnormal LV. This led to LV dilation, LV thinning, and impaired contraction. And this started a vicious cycle of RAAS activation, leading to increased angiotensin 2, increased aldosterone, and these guys, especially angiotensin 2, acted on at 81 receptors, the bad guys, the bad guys, which caused remodeling via vasocon which caused remodeling, including vasoconstriction, increased water absorption, ADH secretion, aldosterone release, glomerular injury. It also activated sympathetic nervous system, increased the sensitivity, right? And then aldosterone acted on collecting tubules and ducts via principal cells and alpha intercalated cells, led to increased sodium water absorption, potassium loss, and hydrogen loss, right? So we want all of these effects to be blocked, right? So we came up with 4 categories of drugs. What are these 4 categories? The first category is the ones acting on angiotensin 2, the angiotensin 2. So the first category is ARNI. So what does it mean? It is angiotensin receptor neprilysin inhibitors. This is the first category drug. And within the first category, there is another category of drugs, that is ACE inhibitors. ACE inhibitors. The third is angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers. The second category is beta blockers. The second category is beta blockers. The third category is mineralocorticoid receptor blockers. Mineralocorticoid receptor blockers. If you are confused, what is a mineralocorticoid? It is aldosterone. It's aldosterone, right? So this drug category, it inhibits the action of aldosterone, and the first category inhibits the action of angiotensin 2, the angiotensin 2. The second category, it inhibits the action of sympathetic nervous system, right? And the last category of drug is this is SGLT2 inhibitors. These are sodium glucose transporter type 2 inhibitors. We did not study much about this category in the slide. However, they do have a role in remodeling. Right? Remodeling. That is why they are included in these 4 categories of drugs for chronic heart failure. So even though we studied the pathophysiology of chronic heart failure, why these 4 categories are important? They are called the 4 pillars of heart failure. And they should be memorized as such, because the maximum benefit would you see is here, and then this, and then this, and then this. Obviously you cannot compare them because they are different classes, but the first pillar would be ARNI, ACE inhibitor, or ARB. The second pillar would be beta blocker. The third pillar would be mineralocorticoid receptor antagonist, and the fourth pillar would be SGLT2 inhibitors, right? So it has been found in research that they benefit patients. How? They decrease mortality. And what does mortality mean? It means they prevent deaths. And then there are and then they also prevent rehospitalization. And because these parameters are important, because any person who is suffering from heart failure, would you like to be rehospitalized again? Obviously, that is why it's an important parameter to study, because quality of life matters, and we also want to make sure that we make difference in the lives of patients in the form of death also, right? We want to prevent deaths, we want to improve their quality of life. That is why these parameters are of utmost importance in research. And these four categories of drugs, they did best. So let's study them. We are done with the pathophysiology, and will now move towards the drugs. Yes, so let's start. Yes, the ARNI. So what is ARNI? ARNI is angiotensin receptor neprilysin inhibitors. So it has two drugs. It's a combination. So what there are two combinations. There is one combination. It has two drugs. So the first drug is sacubitril. So it is a neprilysin inhibitor. It's a neprilysin inhibitor. So I hope this is visible. Yes, and this one too. ठीक. So valsartan is a angiotensin receptor blocker. Receptor blocker. Which receptor blocker? Remember the bad guys? These are 81. So it is a combination of neprilysin inhibitor and angiotensin 2 receptor blocker, which is 81 blocker. 81 blocker. So because this combination was found to have beneficial effects in patients with chronic heart failure, that's why it has been approved. That is why it has been approved. So two or three more most important points to remember about this combination is that they cause angioedema. The second effect is hyperkalemia, and the third effect is called acute kidney injury. So why do these drugs they cause these three? And I think we have already covered these. Let's re-review them. So angioedema, as we as we remember neprilysin also is also involved in the degradation of bradykinin. So when you inhibit neprilysin, there is increase in bradykinin. So once bradykinin increases, it causes angioedema, and angioedema is a dangerous side effect which can threaten the life of the patient. Right? So the second drug, which is valsartan, this causes blockade of receptor of angiotensin 2. So it acts via blockade of 81 receptor. Once you block that, what it does, it blocks the sodium and water reabsorption. Also, it decreases aldosterone, right? As we studied that angiotensin 2 leads to secretion of aldosterone from the adrenal cortex. Let me put it here. Right. So once you block these effects, what would lead to? As we remember that sodium reabsorption led to potassium excretion. Potassium excretion. So if you block the effects of angiotensin 2, what it would lead to? Less potassium excretion, which is equal to hyperkalemia, right? Hyperkalemia. So which can be dangerous, right? These two effects we have studied now. Acute kidney injury we have already discussed. We can discuss this later, but let's dive into hyperkalemia first. So what is the normal potassium? Normal potassium is between 3.5 to 5 milli equivalents per liter. This is the general range for potassium. So once potassium is more than 5, we call that hyperkalemia. Hyperkalemia. Right? So it can be dangerous. How? Let's see. So let's just say this is the normal ECG. This is the normal ECG. And let me draw a few lines. Yes. So if this is the P wave, this is QRS, and this is the T wave. So what it does is, as the potassium rises, it tends to affect the heart. How? First change that we can see in ECG is here in T wave. It leads to tall T waves. It leads to tall T waves. This other important changes that we see here is absent P waves or flattened P waves. And it can also lead to QRS broadening or or sine wave pattern. Sine wave pattern. So why is this important? These electrophysiological changes that we see in ECG, they can stop the heart. They can stop the heart, and which is dangerous. Right? Which is dangerous. And once the heart has stopped, it can lead to cardiac arrest. Cardiac arrest. So it is important to make sure that patient who is taking sacubitril plus valsartan to be monitored for hyperkalemia and angioedema, because both of these two are life threatening, right? Right. So acute kidney injury, as we have discussed, because if this is the efferent arteriole, if this is the efferent arteriole, and we block the receptors, this will lead to vasodilation. Vasodilation. The pressure at the glomerulus will fall, the filtration will fall, and there would be acute kidney injury. So yes, there are certain conditions where I was saying that the flow from the afferent arteriole is already low. That is where the acute kidney injury would happen. What are those conditions? Let me mention. The first condition would be volume depletion. The volume depletion would decrease the afferent arteriolar flow and the glomerular pressure would be already low, and you give valsartan or anything that blocks the effect of angiotensin 2, the glomerular pressure will fall, and the patient will land in acute kidney injury. The patient will land in acute kidney injury. Right? There is an important contraindication to ACE inhibitors and ARB. We'll discuss in the next slide. So, how to identify ACE inhibitors? So, all ACE inhibitors, they have something called prill, not the dishwasher prill. So yeah, um, the prill gives you the identification mark for ACE inhibitor. See, the name is ramipril, captopril, lisinopril, right? All of these have prill here, prill here, and prill. This is not piril, this is prill. It's a mistake, while I was drawing this out. So, how do ACE inhibitors act? The ACE inhibitors, they inhibit the conversion of angiotensin 1 to angiotensin 2, right? And where is this ACE synthesized? We were studying that in the video itself. I would guess, no, I don't think so. Anybody would like to guess. I think they know already. It is synthesized in pulmonary capillaries. Pulmonary capillaries. And which cells? The endothelial cells. The endothelial cells. So, the pulmonary capillary endothelial cells, they synthesize the ACE, and the ACE inhibitors like ramipril, captopril, lisinopril, they inhibit this conversion, and they inhibit the bad effects of angiotensin 2. The angiotensin 2, right? And I remember, and I think all of you remember too, that there are 6 important effects, and one of those is cardiac remodeling. And it is important because this remodeling leads to LV dilation, LV hypertrophy, and LV impaired contraction. So, ACE inhibitors like ramipril, captopril, lisinopril, they inhibit the enzyme called ACE, which decreases the effects of angiotensin 2 by decreasing cardiac remodeling in chronic heart failure, which plays a role in dilation, hypertrophy, and impaired contraction, right? So, as we discussed previously, that ACE is the enzyme that degrades bradykinin. Once you inhibit the enzyme, the bradykinin will increase and it would lead to angioedema. And because we are inhibiting the effects of angiotensin 2, it will cause hyperkalemia. And these two are dangerous. And we don't want that. So, a little bit about angioedema. Once a patient has angioedema, it is a contraindication to give ACE inhibitor because it is life-threatening, right? Simple. Yes. So let's just say you gave a patient ramipril. And he came to you with angioedema. So the whole class of ACE inhibitor would be contraindicated. in that patient. So similarly, in case of sacubitril plus valsartan, sacubitril plus valsartan, if some patients develops angioedema due to sacubitril, it is again a contraindication. It is again a contraindication, right? So we have seen that angioedema is dangerous, hyperkalemia is dangerous. Similarly, acute kidney injury can also be dangerous to some extent. It can be dangerous to some extent, especially if a patient has renal artery stenosis. Why? Let me show you something. So what is renal artery stenosis? So let's just say if this is the kidney, and this is the renal artery, and we have something that is obstructing the renal artery, which is decreasing the renal blood flow, and it is happening in both the kidneys. It is happening in both the kidneys. So the the flow in both the kidneys decreased is decreased, right? So this obstructive flow, can be due to two important reasons. The first is fibromuscular dysplasia. Fibromuscular dysplasia. And the second reason could be atherosclerosis. Atherosclerosis. Right? These two are the important causes for renal artery stenosis, and both of these renal arteries are stenosed. If you give ACE inhibitor, what would happen? What would happen? The renal blood flow would decrease. The blood flow renal blood flow will decrease, and what it would lead? It will lead to decreased GFR. Decreased GFR. Excuse me. It will decrease the GFR. So how does the body compensate? What it would do is, if this is the efferent arteriole and this is the glomerulus Bowman's capsule, and these efferent arterioles, they would vasoconstrict. They will vasoconstrict as a compensatory mechanism, so that the GFR doesn't fall below, so that the filtration goes on. Once you give ACE inhibitor to this patient, right, with both the renal arteries stenosed, the GFR would, because the vasoconstricting effect is lost, the GFR would fall and the filtration would stop. So this would lead to acute kidney injury, especially hands. So this important condition must be remembered because it's a contraindication. It's a contraindication to ACE inhibitors. Also, angiotensin receptor blockers. So yes, ACE inhibitors, which are signified by prils, not the dishwashing fluid prils, ramipril, captopril, resinoprils, they inhibit the conversion of angiotensin 1 to angiotensin 2 to block the effects of angiotensin 2, which can lead to angioedema, hyperkalemia, and acute kidney injury. And ACE inhibitors are contraindicated in patients with bilateral renal artery stenosis. Bilateral renal artery stenosis. right? I think everyone has got that. Let's move on to the next part of the drugs, that is angiotensin receptor blockers. So these drugs, they have common name, or the common part in their name, that is sartan, that is SARTAN. As you can read, this is losartan, valsartan, candesartan, tell me sartan. Oh, tell me more. Well, that was a PJ that didn't go well. So, yeah, these sartans or angiotensin receptor blockers, they block the effects of AT1 receptors. What are these AT1 receptors? As we know, these are the bad guys, and we don't want bad guys to be around. Similarly, like in other drugs, there are important side effects such as acute kidney injury, hyperkalemia. We have discussed both of these two in detail, right? We'll discuss hypotension here. So, in a blood vessel, in a blood vessel, there are 81 receptors. There are 81 receptors. These 81 receptors, they cause vasoconstriction. They cause vasoconstriction. Once you give a angiotensin receptor blocker, which is ARB, the vasoconstriction, the vasoconstriction will be blocked. So what it would lead to? Hypotension. Hypotension. Yes. So I think I've covered these drugs, and we will move on to the next category. The next category. So it is important to remember that not all beta blockers are approved for heart failure. As we remember that these drug categories are research based. These are research based. So they found only three drugs to be beneficial in chronic heart failure. So what are these? These are bisoprolol, carvedilol, and sustained release metoprolol succinate. It is important that if somebody is asked in the exam that which metoprolol is approved for heart failure, you should go specifically for sustained release metoprolol succinate, not metoprolol tartrate. Because it is metoprolol succinate that has been approved for heart failure, that has been tested. It's not metoprolol tartrate, right? So yes, so bisoprolol is a beta 1 blocker, So where are these beta 1 receptors? They are present on heart. If this is the left ventricle and this is the right ventricle and this is the muscle here, the beta 1 receptors, what do? They increase the force of contraction. They increase heart rate. The increased heart rate, right? So blocking the beta receptors on already failing heart helps. Why? Because as you remember, the sympathetic nervous system, it activates. Once a sympathetic nervous system activates, it leads to activation of beta 1 receptors, which increase heart rate, force of contraction, And once because force of contraction is dependent upon myocytes, is dependent upon myocytes, and in heart failure there is loss of myocytes. There is loss of myocytes. The effect of sympathetic nervous system would be detrimental. So we want to block the beta receptors. We want to block the beta receptors via beta blockers, which is bisoprolol, carvedilol, sustained release metoprolol succinate. Right? So the next thing to consider is the side effects. These side effects, what are these? So there are important uh, contraindications which we should remember, which become part of the side effects of beta blockers. So normally, if a patient has acute heart failure, so there is there is compensation, and this compensation is via activity of sympathetic nervous system, which increases the heart rate and force of contraction, right? So beta blockers if you give beta blockers like these, you will block the compensation. This blocked compensation would worsen the acute heart failure. And this patient who had, let's just say, some amount of BP or heart rate to maintain the circulatory flow would collapse, right? So we do not want to give patients who are in acute heart failure beta blockers, because it would worsen the acute heart failure. Similarly, blocking the blocking the beta receptors in blood vessels. So blood vessels have beta receptors which cause vasodilation. What are these subtypes? These are beta 2 receptors. Which cause vasodilation. If you gave a person a beta blocker with already a peripheral arterial disease where the blood vessels are blocked by atheromas, by atherosclerosis, by atherosclerosis, you would narrow the blood vessel and cut off the blood supply. That is why beta blockers are contraindicated in peripheral arterial disease. They would cause vasoconstriction because the beta 2 action is blocked, responsible for vasodilation. Similarly, in the respiratory system, the smooth muscles, they have they have beta 2 receptors. Beta 2 receptors. These beta 2 receptors, they relax the smooth muscles, which leads to bronchodilation. If you block this defect, especially in a patient with chronic obstructive pulmonary disease, where is already blockage of the airways, right? There is blockage of the airways. You will cause bronchoconstriction because you are blocking the smooth muscle relaxing effect of beta 2 receptor by giving them beta blockers, right? Similarly, in a heart where there is a conduction system, where the activity arises from the SA node, goes to the AV node, if this is the SA node, right? And this is the AV node. This is the SA node, and this is the AV node. If you give a person a beta blocker, a patient with already low heart rate, the conduction from here to here would be blocked, and the heart rate would decrease. The heart rate would decrease, and this could worsen heart blocks like second degree Mobius type 2 block or third degree AV block, right? So we are done with beta blockers. Let's move on to the next category. The next category is mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonists. So what are these? These are blockers of aldosterone. So what is the effect of aldosterone? It increases the synthesis of epithelial sodium channels and potassium channels on principal cells in the collecting tubules, or the ducts. So once you block this effect, what it would do? It would cause hyperkalemia, which is an important and dangerous side effect. And second would be acidosis. Right? So these two are important side effects. There is one more side effect that is important for mineralocorticoid receptor antagonists, which is gynecomastia. So I haven't introduced their names yet. These are spironolactone, apelrinone, and finrinone. The first two ones, that is spironolactone and the apelrinone, these are steroid mineralocorticoid receptor antagonist, while finrinone is a non-steroidal antagonist. And it has been recently approved. But not for heart failure, but for other conditions. Our concentration should be only on spironolactone and apelrinone, right? So as we were talking about the side effects of mineralocorticoid receptor antagonist, that is hyperkalemia and gynecomastia, apelrinone has less chance of gynecomastia. And all of you must be wondering why does spironolactone causes gynecomastia. It is because spironolactone blocks the effect of testosterone. And this is especially in case of males. So the only difference between these two is that apelrinone has less chance of gynecomastia. Why? Because it has its ability to block testosterone receptor is less. It has less receptor blocking property. The apelrinone, it has less chances of gynecomastia because the blocking effect of testosterone is less, right? So let's move on to the next category. This is the last category of heart failure drugs, and these are SGLT inhibitors. SGLT2 inhibitors. So SGLT2 inhibitors, they have a common last name. The common last name, just like ACE inhibitors, which had pril, like ARBs, where they had certain. Here it is Flozin. Here it is Flozin. Let me write it down for you guys. It is Flozin. So the first drug is empagliflozin. The second drug is dapagliflozin. So what is the site of action of these drugs? The site of action of these drug is proximal convoluted tubule. Proximal convoluted tubule. What is the channel do they block? They block sodium glucose cotransporter type 2. They block sodium glucose cotransporter type 2. And once they block these receptors, what it does is, because sodium absorption is blocked, it decreases the water absorption also. As all of us know, wherever sodium follows, water also follows, right? So blockage of SGLT2 receptor leads to decrease sodium and water reabsorption. Right? So once this decreases, the volume of blood will decrease. And there would be less load on heart, because the amount of blood is less, right? So SGLT2 inhibitors, they decrease sodium and water reabsorption. This leads to loss of blood. This leads to loss of blood volume. This decreases to less load on the heart, and which is beneficial for the heart. As we all know, stress has been the first event before any of this started, right? Because it started with a plaque rupture, which was because of stress. Remember this diagram where there was this artery, where there was this plaque, and there was stress, which led to the rupture of plaque, right? So there is this common theme for all of these drugs, including SGLT2 inhibitors, mineralocorticoid receptor antagonists, beta blockers, these angiotensin receptor blockers, including ACE inhibitors and ARNI. They all are addressing the effects of stress, and the stress is occurring where? In the heart. Well, this seems to be a better diagram of a heart, So yes, so once you decrease the absorption of sodium and glucose, and it's in the urinary tract, so what do you increase? You increase sugar and in the urinary tract, and there is moisture, and these two they lead to an ideal environment for a fungus, right? So patients who are given dapagliflozin, empagliflozin, or the SGLT2 inhibitor class are at increased risk of genital mycotic infections, because you give them an ideal environment to grow, that is sugar and moisture. So genital hygiene is important. Genital hygiene is important, right? So this is one of the very important side effects in any patient. You prescribe dapagliflozin or empagliflozin. You always tell them that make sure you keep the area dry, you keep it clean. Otherwise, they're gonna have a genital fungal infection. Then there are other effects because we decrease the blood volume. Because we decrease the blood volume, the BP will be low. So the patients would develop hypotension. The patients would develop hypotension as a side effect. Similarly, let's just say patient has diabetic ketosis. Patient has diabetic ketosis. Since we are giving an SGLT2 inhibitors, the glucose is losing from the urine. The patient would be euglycemic. So one of the important side effects for diabetic for for diabetic patients who are on SGLT2 inhibitors like empagliflozin and dapagliflozin, they could have euglycemic diabetic ketosis. Euglycemic diabetic ketosis, right? I believe it is pretty clear to everyone. And if you have any questions, we can review them right now. And I think it's the end of chronic heart failure for all of you guys. And remember, if you didn't remember anything in this video, remember these four pillars. These are, the first pillar is angiotensin receptor neprilysin inhibitors. In the same pillar is ACE inhibitors. And the third part of the first pillar is ARBs, that is angiotensin receptor blockers. The second pillar is beta blockers. And the third pillar is mineralocorticoid receptor antagonists. Mineralocorticoid receptor antagonist. And the fourth pillar is SGLT2 inhibitors. SGLT2 inhibitors, right? So let me see the comment section right now. Uh, what else we can, if there are any questions you guys have right now. Hmm. So I believe uh, the comment section doesn't have any questions right now. So in case you have any questions, the video will be on the channel of Nextillo. The video will be on the channel of Nextillo. You can comment those questions on the video itself and we will answer them either on Instagram or in the next live session on YouTube, right? And I hope all of you enjoyed this experience, and we will be back with more content like this. And it would be great if there are more students just like you guys, with whom I can interact and we can learn together and go forward with every Monday like this, right? So yes, and I think it's almost 8 here, right? And I should say goodbye to all of you, and I'll miss you guys. Bye bye.